All right, let's start. I'm going to have the pleasure of introducing our speaker today. Maggie Lowenstein is a general internist, addiction medicine physician, and assistant professor of medicine at Penn. Her research focuses on novel strategies for implementing evidence-based treatment and harm reduction interventions for opioid and other substance use disorders. She's interested in the delivery of substance use care in general medical settings and in developing and studying low barrier treatment models for substance use disorder. She practices integrated addiction medicine and primary care at Penn, attends on the inpatient addiction medicine consult service, and co-chairs the opioid use disorder work group of the Penn Medicine Opioid Task Force. She received her undergraduate degree at Williams College, a master's in biology and biological anthropology at the University of Cambridge, and her medical degree from Penn. She completed residency training in internal medicine at University of California, San Francisco, and a fellowship in health policy as a national clinician scholar at Penn. Wow.
Really long.
Yeah,
Okay.
you're really well prepared to do this.
I hope so.
And I won't repeat the title because it's right there, but I am going to turn the lights down.
Okay.
Let me know if this becomes too much.
The audience wants a hammer.
Uh-oh. So
right?
this is good. Does that work for everybody? I was going to say it's hard. I can't necessarily look at the online audience and the in-person audience all at once. So I'm probably going to look at you guys, but hi, online people. So I'm going to talk to you about improving care for hospitalized patients with opioid use disorder, which is, kind of falls under that bucket that he was describing about kind of taking care of patients in general medical settings. And I don't have any conflicts of interest. This is the team I work with. So there's a lot of folks from a number of different departments, since addiction care kind of belongs to many groups and also to serve nobody, which is part of the reason we've started some of these initiatives in the health system. And my research mission, as was sort of summarized in the intro, is really thinking about how we can implement some of these evidence-based treatments kind of whenever and wherever patients present for care. So, a lot of my work got started when I was in training in the hospital. I was sort of noticing that we'd be admitting all these patients with, I'm an internist, so we'd be admitting them with infections or other things, and just doing nothing about their substance use disorders, which is, but then when we sort of would say, oh, we're going to refer you to this location for your treatment, they would never make it. And so it was like, okay, there's a lot of opportunity to do things right here and now where people are coming for other reasons. And so a lot of the care that I've kind of done subsequently is focused around that, both clinically and in research. So this is just an example of some of the types of settings that I've worked in or done research in. So obviously the hospital, I'm part of a group that founded this kind of telehealth bridge program, Care Connect, that's based out of Penn, but serves Philadelphia with buprenorphine and substance use navigation services. And then until about a year ago, I also worked on Prevention Point's mobile treatment unit and kind of did clinical work there. So that's sort of the array of the types of things I've done clinically, and also my research is super linked to that. I should say, if there's questions or you guys want to stop me at any point, please do. So that's what I want to talk about today. We're going to do a little bit of background. My training is really as more of a health services and implementation researcher. So all the work that you all do is very intimidating to me. If you have, if any of this is new to you, like, please also, again, stop me as I'm talking about methods and other things that I do. Then I'm going to talk a little bit about some of the work that we've been doing in Penn iteratively to do both research and quality improvement in this area. A qualitative study that I've been leading, for looking at patient and provider perspectives on hospital-based care, and then some of the future directions where we're headed with this work at Penn and nationally. All right, so background, you all know this. We know that there's huge rising morbidity and mortality related to substance use, largely driven by opioid use, although not exclusively, and that there's disproportionate impact on marginalized groups. But you'll also probably know that overdose is really only the tip of the iceberg, and so we're seeing growing hospitalizations and complications from acute infections like endocarditis, osteomyelitis, things like that, chronic infections like hepatitis C and HIV, of course, and also a growing prevalence of wounds. And that's only expanded, I think, with both more frequent injections in the fentanyl era and, of course, xylazine, which is very present here in Philadelphia and probably the driver of many of the admissions we see now, if not like the vast majority. So I already sort of said most of this, but these growth in these hospitalizations has been driven, or we're seeing more growth in some of the more serious infections like endocarditis and bloodstream infections. We're seeing younger ages, more severity, and this is associated with increasing morbidity, mortality, and cost. And we also see that there's like things that aren't going so well in the care, and we can see that by some quality of care that's measured, and also high rates of discharge before medically advised, which is also known as like a patient-directed discharge or discharge against medical advice. Essentially, like the patient leaves before their care is complete, and the team doesn't feel like they should be leaving. Patient disagrees. That's usually a marker of care that's not gone well, and that's very common. And we've shown that actually nationally. Ashish Thakrar led this work that we published in JAMA last year that showed this is kind of these before medically advised or patient-directed or against medical advice discharges in national data from a national inpatient sample. Basically, this is all the AMA rate in all the admissions nationally for any cause. This is the AMA rate for substance use and mental health related admissions that are not opioid use disorder related. This gets a little clunky, but essentially like other substance use and mental health. This is all admissions that have an ICD-10 code for opioid use or opioid use disorder. So they call it opioid related admissions. And then this orange group is injection related infections and opioid use disorder. So we think of this orange group as probably the most severe opioid use disorder and medical complications. And what you can see is like overall it's fairly flat, but among OUD and particularly among OUD and injection related infections, we're seeing this growing group. And so, again, this is national data. This certainly reflects what we've seen here, and I'll share that in a little bit. But just to say that like things aren't going so great. But at the same time, we have this real opportunity during hospitalization. I alluded to this at the beginning. We know that acute care settings are these touch points where people are showing up for care, right? So people come in for overdose, they come in for infections. Sometimes they just come in seeking treatment because they don't know where else to go. And this is this real opportunity to engage folks in treatment. And in fact, when we look at randomized controlled trials, both in the inpatient, like admitted patients and in the emergency department, we see that probably not super surprisingly, when you start treatment in that moment, patients are much more likely to follow up afterwards. I think for this trial, the primary outcome was a little bit later on. And so, but basically this one, if you start buprenorphine in the emergency department, as opposed to giving somebody a referral after discharge, at 30 days, it's more than 70% were engaged in buprenorphine as opposed to like less than 40%. So it's about a doubling of the engagement in treatment in that group. But of course, like these are clinical trials and less is known about how to actually implement these findings into the real world. Those studies came out in 2015 and 2016, and we're still pretty far from having that be a standard of care within these acute care settings. And so that's actually the space where a lot of the work that I do occupies is sort of how do we promote adoption of this, and also then how do we kind of chase the evolution of the drug supply and some of the complexity that we're seeing. All right, so just to highlight again the research to practice gaps, kind of quantify those for you. So when we look at who gets, of the patients who have opioid use disorder, who gets medication started in the hospital, there's not great national data actually, but the one study that is,
shrink this.
Oh yeah.
To get it out of your slides.
Oh, that would be great. Thank you. Perfect. All right. And if anyone on virtually has a question, just, unmute and yell it out, because now we can't see you, but I can see my slides better, so thank you. Yeah, so when we look nationally at a VA population, and this was from a couple of years ago, about 15% of patients who were hospitalized for medical reasons who had opioid use disorder got started on any opioid agonist treatment, so methadone or buprenorphine during that stay. And then if you look at the group that's newly initiated, so people who are not already on treatment, it was only 2% of those, that whole population. So so in that context, which honestly is probably better than most in this regard, they weren't doing a great job. And we don't have great actually national data for all comers in other sources, but that's, I think, again, kind of a decent number to look at. And then when we look at the same thing, when we're thinking about, okay, if someone goes into the hospital, they have OUD and they're admitted for a medical complication, and then we're look at who gets linked to medication for opioid use disorder afterwards, it's even worse. So again, there's a big range in literature, but it's probably less than like 5 to 10% typically in most of what we see at, and so,
I have a question.
yes.
I don't know if it's still standard of care to start someone post-MI on a beta blocker, but assuming it is.
Yeah. Yeah.
I haven't kept up.
Yeah.
What percentage would you guess of people who are hospitalized for an MI are initiated on a beta blocker at discharge?
That is such a good question. I love that analogy because I think it's a very similar one, and I don't know the exact answer to it, but it's a lot higher than that. Yeah.
I mean, it's probably a quality of care marker.
Exactly. Hospitals are dinged on reimbursement if they don't do that.
Right.
It's like, I think some of these, although
that one 50%.
I think at least I would guess more, because I remember being a resident and like your billers or your kind of care manager would be like, are they on an MI? Are they on a beta blocker? Are they enrolled in the post-care program? I don't know if that one is publicly reported, but other data related to MI is publicly reported for a hospital.
Underscores the disparity, the discrepancy.
Totally. And the other reason I like that analogy is that when you look at mortality rates for adults hospitalized with an opioid related infection or kind of an opioid related hospitalization, it's higher than an MI. And so, and these are young people relative to those having an MI. So it's like it's a great analogy in that sense too. And, you know, again, this is like my sort of soapbox that you can probably relate. Like, it would, if we were performing that poorly on cardiology care or on our cancer care or whatever, like we'd all be out of business. And so I think that just underscores how this is not viewed in the same way. And I think that's part of what the work we're trying to do is to change that. Okay, so I'm going to show you some of the data at Penn just to sort of, you know, share. So this is through the end of 2022. These are quarterly admissions, so kind of the same types of denominators I was showing you in the national data at all the downtown hospitals within Penn Medicine, so like Hub Presby and Pennsylvania Hospital. And you can see that like even since 2017, they've gone up pretty dramatically, especially in 2020. Yeah, so a pretty, and this is, and so, yeah, it's a really large increase. Here's our use of any medication for OUDs. This is a little bit of a composite measure, like who got methadone, who got buprenorphine during their hospitalization. This is just hospital data, so it's not necessarily care linkage. But again, you can see it's going up. It's better than national averages from previously reported data, but it's at best about half. So, you know, we may never be at 100%. Not everyone's going to want that, but like this is just anything. That's even in the hospital. Well, that's good. Yeah, we're making progress.
That's good.
Yeah, and I think that shows. I mean, we've an enormous progress since 2017, where we're seeing, you know, between like, I don't know, 10, 25% at the most. So we're feeling better about this. But we also are seeing some things that are not looking so great. So here's our internal patient-directed discharge data, or discharge before medically advised, or AMA discharge. They're called all those things. So about 20%, give or take, are leaving before their treatment is complete. So that's pretty bad. And that confers like a huge increase in mortality, as you might imagine, and also a huge increase in readmissions, which is, of course, a metric the health system cares a lot about. So we're talking about around a 30%, 30-day readmission rate, and that's only within Penn. So because this data comes internally. So I should have said this, sorry. This is data from our electronic health records. So it's not like if someone gets admitted to Temple or they get admitted to Jefferson, this is not in there. And you can imagine people may like bounce around a bit. Yes.
And why are they leaving? Because of long wait time?
So these are folks who are already admitted. So they probably already waited a long time in the ED. So you're kind of selecting out that group who was just like, I can't even wait. The thought, and I'm going to get into this a little bit in the qualitative data, is that we're not doing a great job of managing them, both kind of their withdrawal, their pain, and also just kind of the experience of being in the hospital. But you are a perfect plan, because I'm going to share some data about that. Yeah.
And is this readmission like across the board, or readmission just in
any readmission? And again, this is to give you guys some perspective, you know, hospitals, this is another quality metric that hospitals, you know, they often, there's like kind of payment or other things tied to 30-day readmissions. This is a terrible readmission. Like the overall rate is like 2% or something. It's really, maybe a little, sorry, that's the AMA rate. The overall rate I think is about 5 or 10%. Don't quote me on that, but this is much, much higher than other rates for other conditions.
Here's a question.
Yeah.
What point, I started at the VA with Vietnam veterans, and there was a strong urge to treat Vietnam veterans with substance use problems.
Yeah.
But, nothing was going on in Penn. I'm just curious, what generated the motivation because we always used to talk about how Penn has treatment for all kinds of exotic diseases, except one of the most common ones. And I'm curious to know what's your view of how this got going.
So, I mean, I think it's a combination of things. I mean, I think it's hard to ignore the level of acuity and just how intense this is in our city and in our country at this moment. But I also think there's been a lot of work done by kind of champions who have brought, not just the idea like, wow, this is a big problem, but also like there's things we can do about it.
Yeah.
So I know like in 2017, buprenorphine wasn't even on the formulary at Penn. That's when I came here for a fellowship. So I remember it was like a big deal that it was on the formulary. And I think over time, there's been a lot of kinds of iterative initiatives to try to improve care in the emergency department and the hospital. I'm going to talk a little bit about some of the things we sort of have on the horizon or that we've been doing. But I think it's a combination of just like,
sort of emerged.
Yeah.
If you're familiar with the Christianic Care, Terry Horton developed a hospital-wide system for addressing substance use disorders and transitioning them to outpatient treatment and Christianity. He now works for
DVR.
In DVR, yeah.
Okay.
I'm just curious that it's a very thoughtful using recovery people.
Yeah. So we have been doing that. We've been doing that as well.
Yeah.
But I think there's different models. I want to talk about this a little more, but I'm just talking about it now. I mean, there's a growing kind of consensus among, I think a lot of the leading places that we really need interdisciplinary or multi-specialty care in the hospital.
It's kind of some model that
yeah.
I'm familiar with.
Okay, cool. No, I think that's one that I've heard of. I think there's a few others out there. I think Oregon has been a big leader. Oregon OHSU, Boston Medical Center. A few others have done a really nice job with it. Yeah. They're probably one of the first, but I think there's a growing recognition that exactly what you said. It's we've got to actually sort of have a full system to think about in the hospital and after, and also it's probably not just going to be the doctors. It's probably got to be peers, social workers, other things, because there's a lot of things that are at play here. So the last thing I'll share, and then I am going to get into exactly some of these qualitative data, because I think that'll really flesh out this story a little bit, is just some of the outpatient linkage that we have from Penn. So this is work that I've been doing with part of my K23 from NIDA, which is focused on care transitions from hospital to community. And so what I've done here is linking, and this is all kind of preliminary, but we've been linking data from the electronic health record. Oh, it's probably my email going off. Oops. Data from the electronic health record with Medicaid claims data to try to actually really describe the care transitions more thoroughly, and then kind of use that to follow up the outcomes of interventions, which is a next step. And so again, here's our rate of people getting plugged into medication for OUD after hospitalization. So
pandemic doesn't look like it was a friend.
No, the pandemic has not been a friend. And I think that's, probably you all are familiar, like that kind of mirrors data on overdoses and other things. But it also, in the case of Philadelphia, tracks with some of the changes in our drug supply, like xylazine. So yeah, so green is 2-week follow-up. So anyone who got a prescription for buprenorphine or a Medicaid, a bill for methadone administration within 2 weeks of discharge among Medicaid patients in Philadelphia. The blue is 30-day and the yellow is 90 days. So obviously there's some noise here, but again, I think that mirrors the trend. Like we're seeing overall growth, but like we're missing opportunities.
Pandemic drove some of this. I mean, 2022, which is the height of the pandemic.
Yeah.
It was at its height.
That's true.
Post-pandemic.
Yeah, and I mean, it's a little hard to know what to make of some of this because I think there's some ups and downs, but I think, so it's like this story is basically, we're getting better at a lot of things, but we also have a lot of ways to go. And then as the drug supply evolves, we're sort of seeing new challenges. Here's just breaking that down a little bit more. We see about half and half methadone and buprenorphine from these hospitalized patients, and 16.2% in the sample overall got medication for OUD within 2 weeks. Those who didn't get MOUD but were linked to any kind of addiction treatment at 2 weeks, like a non-medication based, was almost nobody. So basically like if you don't get MOUDs, you're probably not connecting to treatment. And that, again, I think is what we all know and understand, but it's bears out in the data in the real world. And then when we look at the 30 and 90 days, again, it's kind of a mix. Most of the linkage happens within 2 weeks or it's not happening at all. And again, I think that is probably makes sense when you think about it, but is interesting to see when we look at the data. And I'm kind of working on looking at some more details about this data, but so this is hot off the press, but you'll stay tuned. So yeah, again, I've kind of summarized what we talked about, but I think that's sort of the state where we are at Penn when we started thinking more about the hospital and how we could be deploying interventions to improve this. So the next section, I'm going to share some qualitative work that I have done with both clinicians and staff and patients, kind of digging into like what's going on here and how can we improve it and inform some of the things that we have planned and implemented since then. So that's really the research question. And the goal here was to explore the perspectives of the patients, the clinicians, and the staff about addiction care, both during hospitalization and after, focusing on both barriers and facilitators to care. And this is kind of a typical qualitative health system qualitative study. We did one-on-one semi-structured interviews with the clinical staff and clinicians and staff, and then with patients. The patients were interviewed while they were in the hospital. So this can be a hard group to track down. And so we're capturing the perspectives like in that moment in the hospital, but most have been hospitalized previously also. So we kind of are capturing both. This was done in Philadelphia and Penn hospitals, and the patients went first and the providers and staff went second. And I think that is relevant because what we learned from the patients somewhat informed how we did this with the clinicians and staff. And then we analyzed this using thematic content analysis, and I don't need to go into all the details, but we basically there's sort of a systematic way of coding the qualitative data. We have multiple coders to ensure inter-rater reliability. And then we sort of analyze the coded data to extract major themes from it. I don't know if any of you have done qualitative research. It's fun, but probably not the topic of today. So when we look at the patients, this is our breakdown of the characteristics. I think it's pretty representative, I'll just say, of the folks that we see in the hospital overall. And that was we were somewhat purposive in trying to sample representatively. So mean age was 45, 70% were men, about 2/3 were white, and most of the remaining were Black identifying, about 20% were Hispanic or Latino ethnicity, and most were hospitalized related to something directly due to substance use. So an infection, a wound, withdrawal or overdose, and then about a quarter were just kind of incidentally hospitalized for some other medical condition. All but I think one were actively using opioids, and the one remaining person had a diagnosis of opioid use disorder. But you can see that the comorbid substance use was high. A lot of people use, and this adds up to far more than 100. So a lot of stimulant, sedative, and alcohol use concurrently. And again, that's pretty reflective of the folks that we're typically seeing in the hospital. It's the most severe substance use disorder. It's typically polysubstance use.
Maggie, are you seeing under your stimulants, it's Anna Rose, I wondered if you're seeing an increase in methamphetamine. I know cocaine was probably more common some years back, but I was talking with folks at 3801 this morning, and they're saying they're seeing some increase in methamphetamine use concurrently with opioids.
Yeah, so it's interesting. It comes in waves. I would say the majority is people using cocaine, but we definitely do see it here and there, or like a mixture. Sometimes it's not always like intentional cocaine use. Like I was just in clinic this morning, so I was looking at a lot of urine toxicology, and like there were several that had cocaine and methamphetamine, and the person was sort of intending to be using cocaine. So I think it's a mixture. I trained in San Francisco where it was all methamphetamine. So it definitely isn't like that, but it's, but I think it's growing and it kind of fluctuates time to time.
I mean, we've been told that, many times that ice is coming, and we didn't have the big ice waves, if you will, but I was trying to stay in touch with what's happening because there can be shifts, and, some of the projects that we have refer to cocaine use disorder, but if we need to broaden it to think about stimulant use disorder, then we'll try to get ahead of the curve and understand that. But if it's a smattering here and there, that's different than a ground shift.
Sometimes I'll also say there's some limits to this kind of data because we're often based on ICD-10 codes, which methamphetamine isn't great, well captured in ICD-10 all the time. And then we do look at urine toxicology, but again, of course, that's not really diagnostic of a disorder. It's just a snapshot. So, but I would say in my experience, it's gone up slightly over the, like, I don't know, 5 or 6 years, 7 years I've been practicing in Philly, but it's definitely not the majority.
Right. Thanks.
Yeah, no problem. The clinician stuff, this is the demographics of the clinician and staff characteristics. They're, again, I think pretty reflective of the overall demographics of the kind of faculty and staff. This time it's majority women, and it's a mixture of nurses, attending and resident physicians, advanced practice providers, so that's like nurse practitioners, and then we got a couple of social workers as well who do sort of the discharge planning. So again, it was meant to be kind of a variety of perspectives. And so when we talked to folks, we really identified a couple of key areas that really stood out from both groups. And I'll say these were done separately, but a lot of the things are going to overlap. So I'm going to share both together. So patient needs changing. And this is kind of gets at a couple of the questions that got asked, like, why are people leaving? What's going on? And so kind of the growing severity and complexity of what patients are experiencing was really one of the biggest things that came out of this. The lack of preparation and kind of understanding of how to manage this from the providers and the staff was another big area. Bigger systems issues, which is a super generic term, but essentially some like mismatch between what patients needed and what was available was another big thing that stood out. And I'm going to share some quotes for all these. And then really that led to a couple of negative outcomes, primarily this perception from both the patients and the staff that things weren't going well for the patients, but also like a lot of hard time, a challenging challenge and a lot of moral distress from staff. So nobody was really thrilled with what was going on. And I think that resonated in ways that I'll talk about a little bit later. So I'm going to go through some of the examples. So we'll start with the patients, just because I think this went first and I think informs the rest of it. So we heard really 3 big categories from the patients: the changing drug supply, the high level of social need, and kind of priority placement social needs from this group, and then some preferences around communication that patients shared that may impact some of the way that they experience care. So I think overwhelmingly, I think the biggest thing we heard from patients was that with what they're attributing to as changes in the drug supply, with fentanyl, with xylazine, with the potency of everything that's there, they're experiencing severe and growing challenges with pain and withdrawal. And so this person told us, this is a quote from a patient who said, "It takes a lot for us to get over the withdrawal. When you come into the hospital, they, being the staff, are kind of nervous about giving us too much, but we really need that much, not to be high and not to get that same feeling, but just so we can sit still for a minute and gather our thoughts and get ourselves together." And I think you asked about, like, why are people leaving? I think patients overwhelmingly say, I am just, my pain, but particularly my withdrawal is just not even close to managed, and it is nearly impossible to stay and access care when I feel this unwell. And so that I think is like
the withdrawal protocol. Are they protocolized?
Yes, it's changed probably 3 or 4 times in the last couple of years because we're trying to adjust. But right now, clinically, what we typically recommend is starting a medication for you, usually methadone, at least in the beginning, and then adding short-acting opioid agonists on top of it, because the amount, methadone titration, we're also pushing the envelope about how quickly we're titrating methadone. You probably know that there's a lot, historically, we've been cautious in how we titrate methadone, and for good reason, especially in the outpatient setting, there's like lots of risks of going too quickly. But I think that hasn't kept up with what we're seeing clinically as far as people's tolerance with fentanyl. And particularly, this is a group that may be using 2 bundles a day, which one of our colleagues who used to be at Temple and is now at Cooper did some math with some DEA data. It's very, I don't know, it's a little fast and loose, but essentially what he calculated was that 1 bag of fentanyl, which a bundle is usually like 10 to 15 bags, and people, may use many of those a day. 1 bag of fentanyl is probably equivalent to 200 to 300 milligrams of oxycodone, which if any of us took that would be, we'd be dead like several times over if we're opioid naive. So when you think about like what people are getting in the hospital, we aren't even in the same order of magnitude as that half the time. So 40 of methadone. I mean, I love methadone. It's like a magical drug, and I wish everyone can, we could give it to everybody who needs it. But it's not enough even if we're aggressive in our dosing, it's typically not enough to manage people's acute withdrawal and pain. And so I think we've had to really adapt our protocol.
Is the pain withdrawal related pain, or it's kind of nebulous? It's
very nebulous. I mean, most of these patients who are admitted with an infection have an acute pain driver. So they have some horrible wound. They have, they have osteomyelitis, they have, bone infection, skin infection, what have you. So that's often there, but it is really hard to disentangle. I find it impossible basically and I think patients do too a lot of the time. And it's also, these things tend to be, they may be acute, like their bacteria in their bloodstream might be acute, but the one that's been driving it has been there for months. And so like, when does it become chronic? And like, it's hard to separate. I saw your hand.
Does xylazine have a withdrawal?
We think it does. So this is interesting. I didn't put this in the presentation today, but we've done, again, my colleague Ashish Thakkar, who was the lead author on the JAMA paper, is leading a study where we've been looking at some of the kind of physical, like basically trying to understand manifestations of xylazine withdrawal. We're about to submit this paper, but so I just had a baby, so he's been a little busy. But we basically what we did
too, though, didn't you?
Yes, I did. There's a lot of babies in our group. Yes. So his baby is like a week old, so his baby's brand new. But we're trying to submit this paper. But essentially, we did a chart review. We started doing xylazine testing, not universally, but we started doing having the option to order xylazine testing in our hospitals about a year and a half ago, I think. And so we took, we've been looking at all the patients who had xylazine testing ordered that was both positive and negative, and tried to do a kind of detailed chart review about looking at vital sign instability, looking at objective and subjective kind of reports. And there's like there's a lot of like lore out there about like xylazine withdrawal and all this stuff. And what we found, the punchline, which hopefully we'll publish soon, is that it does not look like there's severe physiologic withdrawal. We're not seeing massive vital sign changes. Most people do not need to be in the ICU, and if they do, it's not because of the xylazine. I think, but what is really, really, really notable is just people feel terrible. They feel really anxious. They feel like agitated. But I think for us, it's hard. And then it's also sort of hard to disentangle that from sort of everything else that's going on in the hospital. And what we saw in this chart review is, we're doing a lot of the adjuncts that we use to manage opioid withdrawal are also used to manage xylazine withdrawal, like clonidine, like gabapentin, like, other sedatives, essentially, like things that make people, clonidine's the only one that's maybe targeted, but like essentially we're using a lot of sedatives. And when we manage opioid withdrawal really aggressively and we use adjuncts aggressively, people feel better. But that doesn't really answer the question of like, is it xylazine? Is it high potency fentanyl? Is it just the experience of being in the hospital? It's probably all those things. But what we have seen, and I think what's maybe different from what's being reported, and there's a lot of lore out there, is like, we're not seeing a ton of people getting admitted to the ICU for like, unstable, like autonomic instability, like you would for alcohol withdrawal or, benzodiazepine withdrawal. We don't really see that in the majority of folks. And so I think what we've been doing to manage it has evolved like month to month. I think, we're using a lot of clonidine, again, a lot of gabapentin. Some of our team has started to use a little bit of phenobarbital, but it's essentially sedatives.
Yes, but sedatives that are cross-tolerant with benzos, for example, or even benzodiazepines.
We do use some benzos. That can get a little problematic with negotiating with patients, but we are doing and I think Temple uses a lot more. Jefferson started using dexmedetomidine, which like sort of makes sense, but from a systems perspective, it's hard because that's typically done in an intensive care unit, and it's not clear that is so much better than in these other things. So it's the Wild West, right? Like that's the answer, and we need folks like you to figure all this out. But yeah, clinically, we're really, it's a mess. But I will say, I think that the thing that's really struck me is that the vital sign instability is not there, but what is, what we see just in absolutely like devastating amounts is the wounds. And that is like, I mean, and then I think the infections that are, bacteria gets in through the wound. And so I think this rise in infections is probably a combination of the severity of the use disorder, frequency of injection with fentanyl, but I think also the fact that people have these chronic wounds that are just a portal of entry for bacteria always. And, you know, we do not have the systems to manage them. I'm stealing my own thunder here, but essentially that's the story. And that's really, I think, what is maybe not getting, I mean, it's getting attention, but I think that's where we need to, we also really need to be thinking about how do we address these, because the system's a little broken. So this is, so you hear that, so the patients, and I think to your point, Hank, like people aren't necessarily disentangling all these things, but it's very present for them. The pain, the withdrawal, the discomfort of, you know, whether it's physical, emotional, kind of all of those things, this idea of sitting still. And then of course, you know, the patient's mentioning a lot about xylazine, the wounds, you know, and I think that the fact that the wounds cause pain and are also kind of a driver of ongoing use. So this person talks about the wounds and then they say they don't want to detox, they don't want to come off drugs because the wounds are really painful. They don't want to detox because it hurts, it's a lot to go through, that's murder. And, you know, we hear that a lot. People are just super, they have a lot of pain related to the wounds, which then, you know, means it's that much harder to get into treatment, to get into recovery. And especially when a lot of the settings aren't equipped to manage the wounds, it becomes this really difficult sort of loop, even for like the most motivated folks. And so the other thing, you know, people overwhelmingly, like people's interest in treatment and what they were looking for and whatnot after hospitalization was all very variable, but the overwhelmingly people really needed like prioritizing their social needs. So this person's talking about wanting to go somewhere stable and not scrambling around to get to outpatient treatment and all these other things. Just, I need a place to live, and that's really important. And that makes sense, I think, to most of us. They also just talked about, like, even for folks who weren't unhoused, like there's a lot of, you know, this person's talking about, I'm going home to an infected house with lice, so I'm going to get reinfected when I leave. And the fact that the team just really couldn't understand that. This team said, take it one thing at a time, call pest control. And I felt like saying, you know what, are you going to pay for it? I'm on a fixed income, I'm disabled. That, you know, like just this sort of like survival needs are really important. And, you know, that wasn't particularly well addressed in the hospital. I think we did hear some of the facilitators. I'm giving you like this tiny snapshot of the data, but some of the important facilitators we heard were around communication. So we heard a lot about bad communication. I'm going to kind of spare you that because it's all, you know, there's a lot of being dismissed, just feeling stigmatized. And you know, that is important, but I did want to have some positive things here. So, you know, when people really valued the collaboration with their care teams and like a conversation. So this person shared that they run things by me instead of just doing it. The fact that, you know, you want to know how I feel, that's super, super important to me. They ask a lot of questions about how I'm feeling, differentiating between withdrawal and pain from the surgery. They're making an effort. Like this idea that like there is actually that really goes a long way. And I think along with the pain and withdrawal, and keep coming back to you and pointing at you, but along with the pain and withdrawal, I think this idea that like just people aren't being heard, they aren't being listened to, like they're experiencing stigma, discrimination, whether real or perceived, probably both, you know, that's another reason I think people just are not staying. But people also appreciated this idea of like teams that were willing to kind of work with them. And so, you know, talking about like contingency planning. So saying to the patient, like, if you're having anxiety or this or that, tell the nurse, don't go home. You know, the team basically talking to them and saying like, you know, can we address these symptoms? Don't just leave, like, let's work with you. So that this person said, they want me to stay because like I said, usually I get sick and I leave. And, you know, here's some examples. I shared this earlier that, you know, patients' goals are really variable in the hospital. And I think it's this reachable moment in some sense because, you know, they're obviously facing a you know, acute complication of their use, but it's also really overwhelming and really, you know, it can be really challenging to be in the hospital. And so I think, you know, some people were very motivated at that moment and some people weren't, but for, you know, or I should say, motivated is the wrong word. I think some people had a clear vision of what they wanted after discharge and some people didn't. And I think, you know, we really need to be thinking about strategies that are going to help tailor care to groups sort of regardless of their like preparation. I'm going to go on to the physicians and staff unless folks have other questions. Yeah.
We often make the assumption that people want to stop using.
Yeah.
And, there's a lot of people who aren't there yet.
Mhm.
So how do you handle that? Is there like a group? I know there's core and there's like there's
Yeah.
a lot of peer specialists. Are they using MI to try to help bring the person along a little bit, or?
Yeah, so I'm going to share a little bit. We've started about a year and a half ago. We started an inpatient addiction consult team at Presbyterian, and it's going to be expanding at HUP in January. I think that's been a really big, because sort of to get at your question, I think there's two things. I mean, one is like, if we don't treat them with medication to manage their withdrawal, like an opioid agonist, they're not staying around long enough to have a conversation using MI. And so I think, but also sometimes the physicians or the nurses aren't the best kind of vehicle or the best messenger for this. And so I think what we found, and what's kind of an emerging trend nationally, is that these sort of specialized consultation services that are usually multidisciplinary, including a peer, an addiction clinician, some have nurses or pharmacists, many have social workers as like a really core component, can kind of get at all of these angles, but it's often a precondition, like we must be aggressively managing pain and withdrawal, or we never get to that point. And I think that's where, core is great, but they're not able to do that. So I think we've had to sort of do multiple things at once. And then there is a group of patients that just does not want treatment. And I think I think that's what we've found in some other work I'm not going to share today. We've surveyed clinicians, doctors and nurses, and found that people are increasingly comfortable with methadone, with buprenorphine. I mean, we saw that in the trends. We're seeing more and more methadone and buprenorphine being used in hospitalized patients. What they are not comfortable with is like the gray area, like someone's not sure about treatment. Someone's like, I'm not ready right now. And that's like, that's always going to be a group of people, and we need to provide them with medical care as well. And ideally, we're keeping them in the hospital and treating their infections. And I think, and also arming them with resources around what to do when you leave. Like, how do you get sterile syringes? Well, now in Philadelphia, we're in a whole mess with that. But like, yeah, that's not going to help any of this. But how do you get your wounds cared for? How do you keep yourself safe? And so I think we also need to be prepared to have those conversations. And I think it's both. But everybody across the board is much less comfortable with that latter category, which probably makes sense. Yes.
In the hospital, you have all the resources available that you just described, social work and everything. What's been your experience making that transition in a chronic relapsing disorder? Your experience in making, once you get somebody all tuned up, so to speak, and all of them, what's your experience in making that transmission so some quality care can continue?
Yeah, I think that's been very hard, because both because of the high level of need that patients have, and the fact that we don't have great housing and things like that. But also I think the stuff that we do have control over, we're not necessarily always making it as easy as we could. Like, I think so where I've seen success is really like integrated models, I will say, and lower barrier models. I mean, again, I think there's models for the need, like different models fit different patients, but for this group in particular that we're talking about, like they can't go to 20 appointments. They can't go to, they have trouble holding onto a phone. They have trouble. So we really need models that are going to accommodate that. I know something we've been working on for a long time here and trying to build out is our primary care integrated clinic. That's where I work, and we have some in internal and some in family medicine. And I wouldn't say we're, perfect, but I think one of the things that we do well is we're very, we're offering buprenorphine, we're offering primary care, we're doing hepatitis C treatment. We are we have peer recovery specialists. A big challenge is psychiatric and mental health care, I'll say, because that's a big access challenge for this group. But we do a lot of management ourselves, probably could use some help on it, but and so we try to basically incorporate as much as possible into our model, and we try to be very flexible. So like I was in clinic this morning, we saw a patient who was 4 hours late, and like we do that pretty routinely. And I think that's one of the pieces that's really critical for this group. We provide SEPTA passes for transportation. We have a program we've got a grant to do like this kind of supplemental food box, it's called, basically supplements to food stamps that people are eligible through their Medicaid benefits or along with Medicaid benefits. So really trying to think about like, we provide phones, although again, they often get lost. So we kind of have to like be adjusting. But I think one of the challenges with this group is that like any single model is really hard for them to access. Like everything kind of needs to be together. And that's part of why I say we were referring people to ID for hepatitis C treatment, and then nobody was going. So we're like, okay, we're internists, we can do hepatitis C treatment. So we like figured it out. And so, so we just started like, we've kind of added things on over time. It's not perfect by any means, but I think we need to be moving in that direction because this group is just really going to struggle to make their, very set appointments and their very, separate services and so I think we're looking always to do more of that. And I'm gonna kind of breeze through this because we're sort of I want to get to the end about the consult service. So the physician and staff piece really kind of mirrored the patients in terms of the pain and withdrawal and the real difficulties that the staff experienced around trying to like, how do we, I'm seeing patients with all of these, both complicated substance use disorder and complicated medical issues, and it's really challenging to manage all of these things concurrently. And, also that this person is talking about their, knowledge and comfort, like they're not super comfortable with this. And then it's like fentanyl, xylazine, everything's happening so quickly that not only, that they're learning on the job, but also they don't even know what they don't know is kind of, and this was expressed sort of over and over again. Like we just don't have we don't know how to manage this stuff and we don't know where to go to get help with that. And this speaks to some of the things I was talking about earlier. It's, one of the residents shared that, the thing that comes up is that inpatient substance use rehab facilities can't take the medical problems. And so if a patient has wound care, they need to be performed. There's very few facilities that will take those patients. The places that will do wound care often won't take patients on methadone or struggle with, buprenorphine or, and that versions of that happen post-acute, that happens in the outpatient, that happens really everywhere. And I think our systems just have not kept up with the needs that are present. And this is, I'll tell you, as the addiction consult attending, like a huge sticking point. Like half of our work is like, okay, where can we put this person? Who's going to take that? Where
it used to be psychiatric, cohort psychiatric that were an impediment to placement. But now it's probably.
And honestly, I think we're just ignoring the co-occurring psychiatric disorders, which is not a good thing.
There's a lot of medical acuity.
Yeah, but there's not. Yeah, but I think it's all of those things, and then once the medical acuity hopefully gets better, the psychiatric disorder remains untreated, and I think this is a real challenge. I see that. Like I said, on the inpatient, honestly, I think we're largely ignoring it. I see that a lot on the outpatient. It's like we're trying to figure out how to help this patient, but we're struggling to access. And then again, kind of mirroring the patients, we're hearing over and over again that like, we don't have great resources for homelessness and other sort of social needs. And as I alluded to in the beginning, like this is really hard for staff. It's really hard for patients. And I think that's the main message, but this is also hard for staff. So, this nurse was sharing that it's hard when someone's withdrawing, they don't feel good. There's only so much you can do and people end up leaving. So it's hard because you're begging them to stay, but you're not doing anything for them. That's a horrible feeling as a clinician, and leads to a lot of, frustration, moral distress, and like, just, I think reinforces some of the stigma and like unpleasantness of taking care of these patients when you don't feel good about how you're doing it. And so again, just sort of, I think this is my little like cheesy Venn diagram, but I think these things are obviously all interrelated, and it's hard to create a system, or it's hard to address one without the other, and I think that's really where we're trying to think about going next. So this is summarizing the patient. I think the patient provider dynamics are complicated. So there's lots of negative experiences that the patients reported. I didn't share as much of that, but also that communication actually could go a long way with the patients. It's not going to fix, xylazine withdrawal or xylazine complications, but just being felt heard and, listening to the patients and responding, even if it's not perfect, did go a long way. And so I think, in thinking about what can we do now versus what can we do later, like going back to basics can be very helpful. And I think providers, sort of understand that there's gaps here. And so there's a real appetite for things that can help with that. I highlight the workforce stuff just because this has been, it's in the literature, but I think now from before, but I think now that there's this real focus on healthcare workforce burnout, there's this moment that we have to kind of emphasize this, and I'll share that that's something we've been trying to both talk about and measure as we do some of the interventions that I'm going to describe in the hospital, like the consult service. Because I think, that as much as quality of care and other things, that's something that's a real priority among the health system leadership. And so kind of trying to use that as another metric in our aims has been something that we've been kind of highlighting. And it has been very salient with our leadership, as I say here. And again, this sort of summarizes what we were talking about with just the mismatch between what patients need and what's available, and trying to tie those things together. It's very hard to, we really need multi-level strategies in order to do that. So I'm going to talk a little bit in the last section. We have about 8 minutes left. Okay, so we'll go fast, but hopefully you got your questions answered as we talked a little bit, and I'm happy to stay after if people have other questions. I'm going to talk about what we're doing now. So I think I've alluded to this a bunch of times. Inpatient addiction consultation models for hospitalized patients are becoming a growing strategy that people, I think many academic medical centers and other places have started to implement. Sort of like what you were talking about at Christiana. I think this recognition that, we need a combination often of addiction specialists, social work, peer support, nursing, pharmacy, all really great, because this isn't like one group's problem to manage. This is all, we have to be managing the clinical, the social, the discharge planning, all of those things. And I think of this as sort of a multi-level strategy. It's not the perfect fix, but, I think it obviously helps with patient care, but for the reasons I've shared, I think it helps with some of the staff, empowering staff and also supporting staff. And I think, it helps, it doesn't fix all of the systems gaps, but I think it helps sort of identify and leverage the resources that we do have to their maximum benefit. I'll be excited to see, I think people are studying this, myself included, but I think understanding the role that this might play in things like stigma reduction, because I do think, part of one of the many threads that contributes to stigma is this idea of like, well, I can't do anything about this, right? And like, I don't like doing this because it makes me feel bad. And I think that is not helping. That's a component of stigma that we see in the setting. And I'm curious if with better, both kind of more empowerment around how to manage this, modeling from peers, other things, like we might see some reductions in that. Probably not the, magic wand, but I think that's an interesting thing to be thinking about. So, there's growing evidence for these models. It's emerging nationally, again, sort of around quality of care for patients. That's this bucket, including one study by a colleague who was at Pittsburgh and is now here, Deanna Wilson, that showed reductions in mortality for patients who received addiction medicine consults at Pittsburgh. There's also improvements in some of the relationships and the physician and provider-patient dynamic, including increased patient trust and kind of reduced moral distress. So think about some of the mechanisms by which this may work. And we see reduced readmissions and ED visits. Hot off the presses is this cluster randomized controlled trial that came out like 6 weeks ago, which is a trial of implementation of these of a interdisciplinary consult service in New York City Health and Hospitals. It was looking at sort of outcomes for all the patients in the hospital, given that the intervention was kind of at the hospital level. But what they showed was, patients who were in a consult hospital had substantially higher odds of getting medications for OUD at the point in the hospital, as well as after discharge and remaining on MOUDs. So odds ratios in the 8s and the 7s there, which is very high, obviously. But overall, the use was still pretty low, not as high as we have here. As you saw, so like 14 days after discharge, it was 11% of patients were on some sort of medication for OUD who were in the intervention hospitals versus 7 in the control. At 30 days, it was 7 and 5, and 6 months it was 3 and 2. So again, like sort of mixed evidence. This was the way that this is the first big trial that came out in this, and they didn't necessarily share all the ways in which what was the adoption, how far, what was the reach of this intervention, things like that. And so I think
I realize that odds ratio is not the same as a simple portion.
Yeah.
But an 8 times higher odds for 11% versus 7%, that doesn't seem to compute.
I think so. That's a good point. You're right. I don't know.
I mean, because 8 times higher odds is really impressive for
yes.
anything. But 11% versus 7%. Seems like about a 50% increase.
Yeah, I'm wondering if I took this, I'm wondering if I stated which outcome we're talking about. I'm wondering if this might be, yeah, can I get back to you? Because I think I may have miscopied. I'm getting tangled up in my own head, but you're absolutely right. That doesn't actually, that doesn't pass this little sanity check. Yeah, no, let me find that out because I feel like that doesn't make sense. I mean, so, we're doing something similar here. We've done a few different things. So as I mentioned at Presbyterian and soon to be at HUP, we have a pretty built out interdisciplinary addiction consult service. So an addiction medicine physician, I attend on this, many of my colleagues do. We also have a fellowship for addiction medicine trainees who work on the service. We have a full-time social worker. We have a peer. At HUP right now, they've been doing kind of a mixture. So there's like the men's service, which does kind of mental health and consultations. And then there's the psych CL, which is more general. They also have the core team, and then they have a pain and addiction pharmacist. Those groups work somewhat in tandem, but it's not necessarily a fully scaled interdisciplinary model. And so we're going to add that on at HUP in the next few months. And so one of the things that our team is really excited about is actually to kind of leverage some of this variability in implementation and look at our own outcomes, because I think, there's obviously lots of value in these large randomized controlled trials of implementation, but I think the field is moving very quickly and we have these opportunities to leverage some of the changes we're doing within our own system. And so that's something that I'm working on as kind of the later aim of my K23. We're also doing kind of a second round of surveys and interviews kind of post-consult implementation to understand both what's going well, what's not going well, how can we refine the model, how can we use that to inform what we do next. So that's sort of things that are ongoing in the pipeline. And then the other thing that we have, this is like my second to last slide, so I will stop momentarily. But Project Home is a local kind of housing organization that is probably, I think, the largest in Philadelphia, and received this large philanthropic donation to support, I don't know why that just went automatically, but it just told me to move on. It's large philanthropic donation to support the implementation of a sort of transitional housing and care model for exactly this population we're talking about. I don't know why that's going. That's super weird. Yeah, it does. So anyway, so I have an R01 under review to actually kind of study the implementation of that model for this patient population to understand, does it improve outcomes in terms of substance use treatment engagement, housing retention, and mortality. And so that's something that hopefully is getting, I was reviewed and I just resubmitted it in July. So hopefully we'll get that, that will get funded this round. We'll see. But I think that's a kind of more high touch model to serve the medical, the social, and sort of transitional needs of this group. So here are my conclusions. I think, again, we've talked a lot about how hospitalization is an important moment, but also a challenging one, and how we need multi-level strategies to really address all of these different gaps that we're identifying, and that, consultation in the hospital is one growing model that we're doing here and many places nationally are doing, but that it's very quickly evolving. And so this is kind of a very active area of study and in the literature. All right, and I think it is exactly 4 o'clock. If these are my children, so I had to add that. This is my new guy, and one of my addiction medicine colleagues got me this onesie, so I have to put it in all my talks now. And his older sister, yeah. So, because we gotta have her. That's the whole thing. So everybody's here, but yeah. So if you guys have questions and you have to run, feel free to email me. But I'm also happy to stay and chat. And thank you to everyone online as well for listening in. Appreciate being invited.